Echo is a technique based on ultrasound, but it uses it in a variety of ways. We'll just outline these different modalities so that you can appreciate the differences and relate them to how you're going to be using the echo machine. So if we look at this diagram, let's imagine our probe is here and it's emitting this ultrasound, and we can describe the ultrasound by its amplitude or power. And we can also talk about its wavelength. So this is this length here for a whole cycle of the ultrasound. And then we could talk about frequency, which how many of these cycles we might get in a second. Frequency matters because it affects resolution, with high frequencies giving better resolution. So there's high frequencies, there'll be low wavelength. However, the trade-off is that the high frequency waveforms have reduced penetration. So as an echocardiographer, you're going to be making judgments about the frequency you want to use in a given situation. The velocity of the beam depends on the characteristics of the medium it's actually travelling in. Okay, so now we're going to think about how we actually make the echoes. Ultrasound behaves in a complicated way, so we're going to simplify it here. We've got a probe here against the chest, and we're putting ultrasound into the patient. If you have tissues with different acoustic impedance and there's a boundary between them, something happens to the ultrasound. Some of it will carry on and be transmitted. Some of it will be reflected. And the degree to which these occur depend on the different acoustic impedances of the tissues concerned. So it's quite fortunate that muscle and blood have very different acoustic impedances. And bone, for example, has a very high acoustic impedance. So these reflected beams here, these echoes, are what we're interested in. Now, the ultrasound is delivered in pulses. They go into the body, there's a pause, and then reflected back. And the machine will wait for them to come back. And it can use that time to work out how deep the echo has arisen from. So for the start of this echo here, by how long it's taken for the ultrasound to get there and back, it can tell us where this boundary is. Obviously, the ultrasound that continues can then give us information about structures deeper into the chest. Now this is a 2D image. The probe is up here. The ultrasound is being emitted. The machine is waiting for it to come back, and then it's sending the next beam down. So it does this, it sweeps across the sector like this. Now you can see that this has to be done frequently enough to give us the information to assess the structures we're looking at. So for example, the mitral valve, if your heart rate is 60, is going to be opening and shutting every second. We'll want to see that several times, many times within that second to know exactly what it's doing. So you can see how this temporal resolution matters. But then you can also see that if you've got two structures next door to each other, you need to be able to separate them. So it's how wide these beams are will affect that. And then the other thing we need to think about is axial resolution. So for a structure near the probe versus a structure a bit further away, how well we can differentiate those. And that's dependent of the frequency of the ultrasound beam. So this is what these look like on a 2D image. So just like the cartoon, the probe is here, and these other scan lines are coming down as the sector updates its image. So it goes from here over to here. So you can see how the lateral resolution is being affected. You can see how our temporal resolution is being affected as we look at this mitral valve here, and how any resolution in this plane, our axial resolution, will be affected as well. So what you need to remember is that you, as the echocardiographer, can control all of those things. Okay, and that's a very important thing to remember. So the next modality we're looking at is M mode. So we've got our 2D image, just like we've been looking at up here. But if you look, there's a line going down here. And what we're doing is just looking at that beam. It's like taking a graph along that line through our 2D image. So we're looking here at time on the x-axis. On the y-axis, we've got distance. And what we're doing here is we're scanning through the aortic root. So these two lines here are the walls of the aorta. And we're looking here at an aortic valve. And this is a bicuspid aortic valve, and you can tell here our closure line is a bit off centre. This is something that can be quite difficult to see on 2D imaging if the heart rate's very high, but on M mode, because it's so good at picking up motion, we can see this quite well. So there is still a role for M mode, although we don't use it an awful lot nowadays. So the next thing we're going to talk about is pulse wave Doppler. So you need to look really carefully here at this little diagram at the top here, this little picture. So we've got two parallel lines here, which is showing us that we're sampling. That's a sampling point for our pulse wave Doppler. And what's happening here is we've got the probe up here, and we're sending ultrasound into the heart. But instead of using the tissues as our reflectors for the ultrasound, we're actually bouncing it off the red blood cells. And what happens is if the red blood cells are moving away from the probe, the frequency of the ultrasound will diminish, but if they're moving towards it, they will increase. Now the machine is able to convert these changes, these Doppler shifts, into velocities, and that's what it displays here on the y-axis, velocities in meters per second against time here. Doppler modalities only work well if you are perfectly lined up to flow, so you're parallel to flow. So this is flow here going out through the aortic valve. You can see our line here is beautifully aligned to that. If it's not, you will underestimate your velocities. So you can see on this little picture here, there's this colour. So let's move on and talk about that now. So this is colour Doppler, or some people call it colour flow mapping. You can see we've got this sector here, that's our colour flow sector. And what it's doing is very similar to what pulse wave Doppler was doing, but instead of giving us hundreds and hundreds of little graphs, it's actually giving us blobs of colour, or pixels, doing exactly the same thing. You can see here we've got a colour scale, and this reflects the BART convention. So let's imagine our probe is here, which is here, and we have blue away and red towards. So any red blood cells travelling this way, travelling away from our probe, are going to be colour-coded blue. Whereas blood coming into the ventricle and towards the probe, it's going to be colour-coded red. Now the actual shade of the colour will depend on the velocity of the blood cells. And you can see here on our scale that as things get faster, the colour gets more intense. So now we're going to talk about continuous wave Doppler. So again, let's just start at looking at our line through our image. You can see we've got a continuous line, all dots. There's no little tram lines like we have on the pulse wave. So what's happening is the probe is emitting and receiving ultrasound continuously, which sounds great, but there is a downside to this. Because it's not sending out pulses and waiting for them to return, it can't tell us the depth at which the ultrasound is arising. So for example, these velocities I'm seeing here, they could be coming maybe from the apex of the ventricle or mid-cavity or at the aortic valve. You'll notice that the display is very similar to what we see in pulse wave Doppler, with velocities here on the y-axis and time on the x-axis. So you're probably thinking, well, in that case, I'll probably just use continuous wave Doppler all the time, because at least I know where I'm getting my signals from. But unfortunately, it's not so easy. So again, we're now looking at a pulse wave signal, and we can see that because we've got our little parallel lines here showing us that that's where we're sampling from. So here we're in the outflow tract of the left ventricle, and it's giving us this signal here. However, if you look here, there's lots of sort of crazy display, and that's because this patient has aortic regurgitation. Pulse wave can display signals up to about 1.5 meters per second. If it goes over that, it has a problem. And it's related to the fact that because it's waiting to receive ultrasound before it sends the next signal out, it can't sample the signal frequently enough to display it accurately. And then what you get is this rather confusing sort of wraparound signal, so where it displays velocities both above and below the line. We see something similar with colour Doppler, but then it can be quite useful because this sort of crazy bit is just shown as lots of mishmash of high velocity colour, which can attract us to turbulence or stenosis. So the trick as an echocardiographer is to use continuous wave and pulse wave Doppler intelligently and sensibly. So play to their strengths. If you need to measure high velocities, you'll be using continuous wave. If you need to localise, you'll be using pulse wave. And sometimes you'll be bouncing between the two to try and work out what's going on. So the last modality we need to think about is tissue Doppler imaging. This shares a lot of similarities with the other Doppler modalities we've been talking about. But in this situation, we're actually colour-coding the myocardium. So instead of using the red blood cells as our reflectors, we're actually using the myocardium, the walls here. It has the same convention, the same BART convention, blue away and red towards. But you'll notice if you look at the colour scale, the velocities are much lower, and that's because the myocardium is moving much more slowly than the red blood cells would. Modern echo machines can do a number of other things as well. But if you use the modalities that we've talked about in this lesson, you're going to be able to make a pretty good assessment of most cardiac abnormality. And you can always ask for the other modalities at a later date if you require them.